I'm Wang Jian'an from Second Affiliated Hospital. Now I'm going to start the delivery remarks. Dear distinguished panelists, audiences, and organizers, good morning and good evening to you from different parts of the world. Please allow me to welcome all of you to join JACC Asia webinar series, Coronary Physiology Update. I feel so honored we have an international and respectable panel today. They are Dr. William Fearon from Stanford, USA, Dr. B.K. Koo from Seoul National University, Korea, Dr. Jian'an from Essen Medical Center, Korea, Dr. C.W. Nam from Keimyung University, Dongsan Medical Center, Korea, Dr. Chen from Singapore, so Dr. Pu Jun from Shanghai Region Hospital, China, Dr. Guo Lijun from the Third Hospital, Beijing University of China, Dr. Lianglong from Fujian Xiehe Hospital, China, Dr. Zhang Junjie from Nanjing First Hospital, China, Dr. Xinyang and Dr. Jiang Jun, both from Second Affiliated Hospital, Zhejiang University, China. So also I would like to thank all of you for your great contribution to JACC Asia, including submitting your excellent manuscript, reading thoughtful comments, and reviewing papers. So thank you so much for joining the webinar. Okay, good. The title of my presentation to introduce you to JACC Asia is Shape the Future of Asian Cardiovascular Community. JACC Asia is a new journal of JACC family. Until now, JACC family has let me count 1, 2, 3, 4, 5, 6, 7, 8, 9. Actually, until now, JACC family has 9 members, but they are going to have a new member very soon as a JACC Advance. So here I listed the starting time of different members of JACC family, also impact factor. So JACC, the impact factor of JACC already rise to 24, and the whole JACC family looks like having very good impact factor. So JACC Asia is the first regional specific journal of JACC family. It is an online and only open access journal. The first issue has been published on June 15, this year, 2021. So what are mission of JACC Asia? JACC Asia is going to publish original research on Asian population-focused cardiovascular diseases. It will highlight cross-disciplinary studies and the comparative studies between Asian and the rest of the world. JACC Asia will nurture and encourage Asian-based investigators to conduct high-quality cardiovascular research based on Asian data. Prevention is also JACC Asia's responsibility. So we inspire submission of prevention of cardiovascular disease and improve the prognosis of this type of articles. Here's the model of JACC Asia. So each letter has different meanings. So JACC Asia is always on the way. So it's a journey. Accessibility means the journal is an open access journal. So cultivation means the JACC Asia has a responsibility to do the education, to cultivate the young talents in Asian cardiovascular community. So JACC Asia will have a widely collaboration with experts, international experts, with famous institutions, with other journals, not just the JACC family, but also the other journals outside the family. The JACC Asia is actually, it has its own advantages. It will provide a high quality service. So innovation is novelty is so important for publication in JACC Asia. So JACC Asia is always expect the staff and investigators to work together to have a better future. And so I have the opportunity to work with a wonderful and engaging editorial board. So besides me, we have 3 deputy editors. Dr. D.W. Park, he's a very good international cardiologist. Dr. Xinyang, she's a very famous EP expert. Dr. Zhao Dong, he's quite good at epidemiology. Actually, she submitted a wonderful review in the first issue of journal. Professor Chen is also a very good international cardiologist. Work as a AE. Professor Jiang from Taiwan is working as an AE. Dr. Fu is also work as an AE. Dr. Kubo and Dr. Lam both work as an AE. So there are many archetypes you can check on the author instructions. So there are two types are quite unique in the JACC Asia. One is the cutting edge technology. The other one is Zoom in. So cutting edge is we inspire to submit some new technology just emerge in the, maybe you have just finished the big animal study or just start the first in man or some of the feasibility studies. So the Zoom in is focused on the education, focus on one area to do the education. Until now, we have a total submission from February 9, we already have total submission more than 140. So most of the original papers every year growing very quick. So here I listed the contributions from different countries and different areas. So until now, the acceptance rate is 13%. So rejection rate is 37, but the others still pending or waiting for the revision. With your great support and so many experts from the world, the support. So the first issue has been released. There are two wonderful reviews and 6 original articles, plus 6 editorials, and 1 research letter and 2 landscapes were published on the first issue. So what is JACC Asia looking for? We are looking for original research, cutting edge technology, and clinical recommendations. Especially we need we have not published clinical recommendation on the JACC Asia on the first issue, so we are welcome clinical recommendations, so including consensus and guidelines from different countries or areas. So we are looking for cross-disciplinary studies where Asian researchers hold a competitive edge and comparative studies between Asia and the rest of the world. So we are looking for the high novelty, high quality, and ethics manuscript. Thank you for your attention. That's all for my introduction. Thank you so much.
The opportunity to briefly talk about coronary physiology in the cath lab. These are my disclosures. What I'll try to do in the next 10 minutes is just overview the importance of coronary physiology in the era of the Ischemia Trial, the importance of the coronary microvasculature, coronary physiology in the acute coronary syndrome patient, and wireless coronary physiology. And just, I know a lot of these are going to be discussed in subsequent talks, so I'll just highlight some thoughts that I have about them because I think they're kind of the key topics currently in coronary physiology. So we're all aware of the Ischemia trial and how it did not show any overall benefit with revascularization versus medical therapy, but it did clearly show significant angina relief in patients undergoing revascularization compared to medical therapy that lasted out to 3 years. And this coincides with some work that Dr. Takeshi Nishi, when he was a research fellow with us at Stanford, did looking at a combination of FAME1 and FAME2 patients who were stable and treated either medically or with PCI, and looking at the effect of PCI on their quality of life. And basically what this chart shows is the change in quality of life from baseline to 1 month, with the higher values being greater improvements in quality of life. And what you see is that with PCI, there's a graded increase, and it gets more and more based on how low the fractional flow reserve was, suggesting that PCI really does improve or relieve ischemia, and that improves symptoms. If it was just a placebo effect, we would expect all of these patients to improve in a similar fashion, regardless of what their FFR value was. But you see that there really is a graded effect. And even if you look at delta FFR, so the FFR after PCI compared to the FFR before PCI, the patients who had the greatest change in FFR had the greatest improvement in their quality of life. And then in the FAME2 trial, we found that at 5 years, there was lower rate of myocardial infarction in patients who had low FFR when they were randomized to PCI compared to medical therapy alone, suggesting changes in hard endpoints too. And that was also seen when you looked at spontaneous MI. And Ischemia also found this. They found lower rates of spontaneous MI, or non-procedural MI, as they called it, in the invasive arm, the patients who got revascularized compared to the conservative arm. So that correlated very well. So I think, although some people have interpreted ischemia as a negative trial for revascularization, I think we can conclude that it improved revascularization, and particularly PCI, improves quality of life and angina, and also can reduce spontaneous or late MI. Now, the other area I wanted to mention was the microvasculature. We often focus on the epicardial vessel because that can be fixed with stents or bypass, but the microcirculation is clearly important. And we can assess that with physiology, both by looking at microvascular resistance and also looking at coronary flow reserve. And there are studies like this one from Jung Min Ahn looking at patients who had abnormal microvascular function, both with low CFR and high IMR, having worse outcomes during longer term follow-up compared to the other groups. And this study too, which found that patients with high IMR, particularly if they had endothelial dysfunction, had worse outcomes compared to patients with preserved microvascular function. And then the CORE-MICA trial was a very important study because it showed that we can use this information to help guide therapy and improve patients' symptoms. And so in CORE-MICA, they did a very thorough evaluation looking for microvascular angina, vasospastic angina, or non-cardiac chest pain if everything was normal. And then they randomized patients to this assessment versus just standard of care, and found that by stratifying patients and then guiding therapy based on what the diagnosis was, patients had improved outcomes during follow-up. And then another study that we did, which was a multi-center registry, including a number of centers from Asia, particularly Japan, was looking at the role of measuring microvascular resistance, or IMR, after performing PCI in patients who are stable, and finding that those patients who had high IMR, so they not only had epicardial disease, but they had microvascular dysfunction, had a significantly worse outcome with a higher rate of death or spontaneous MI during long-term follow-up. So I think this is an emerging area of investigation that is going to continue to grow, and hopefully we'll now be able to develop therapies for these patients that'll help improve their outcomes. I briefly wanted to say a few words about coronary physiology in patients with ACS. There's been a lot of question about whether we can rely on FFR or non-hyperemic pressure ratios like IFR in patients who have particularly STEMI, because of all the changes that are going on in the microvasculature, which can lead to variable microvascular dysfunction and transient microvascular dysfunction that can affect FFR. And these changes can also lead to hemodynamic changes in heart rate and blood pressure, which might lead to increase in resting flow and therefore affect your ability to measure non-hyperemic pressure ratios in the non-culprit vessels. Now, fortunately, studies that have looked at the non-culprit FFR have not shown real significant differences when you measure it acutely compared to, a week later. IFR also does not have really dramatic changes, although in this case it was statistically significant, but a small change in IFR in the non-culprit vessel. In this other study that looked at IFR, they did not see a significant change from the IFR in the non-culprit vessel acutely compared to about, 1 month later. However, in this study, they did see a significant difference in FFR, but all of these studies have shown that these changes are small. And so I think we can rely on the physiology, but the question has come up is whether these plaques in the non-culprit territories, are they more active? And maybe even if they have a negative FFR, they're more likely to have events. And that was suggested in this study, which compared stable angina patients to ACS patients and showed that when you deferred non-culprit lesions based on FFR, there was a higher event rate. But I would argue that the comparison should not be between ACS and stable patients, but it should be whether PCI of these non-culprits that were deferred based on FFR actually improves outcomes compared to medical therapy, because we know ACS is a different group of patients. They're higher risk. They're more likely to have events no matter what we do. So it may not be that this is a failure of coronary physiology. It may just be that this is a higher risk cohort. And so when you look at this graph from that study, you see that the deferred ACS, shown in orange, had higher event rates than the stable lesions which were deferred. But the treated patients in ACS actually had even higher events. So maybe, if these patients had gotten PCI, they would have a higher event rate. So maybe just treating them medically is the way to go. And this was kind of looked at in the Prospect 2 absorbed sub-study, where the patients had non-flow limiting non-culprit lesions that were randomized. So they were FFR negative and randomized to either bioresorbable vascular scaffold plus medical therapy or medical therapy alone. And you see that there really was no difference in outcomes, suggesting that treating these lesions was no better really than medical therapy alone. And this was despite the fact that these were felt to be vulnerable plaques based on increased plaque burden when they on IVUS. And then finally, the most recent study, which has raised questions about physiology in non-culprit lesions, was the FLAVOUR MI study, which included over 1,000 patients with STEMI and multivessel CAD and randomized them to either FFR-guided PCI of the non-culprit disease or angio-guided PCI. And you see that there was no real difference in death, MI, or urgent revascularization. But some of the reason that there might not have been much difference is because all of the patients included had a STEMI and primary PCI, and likely that would drive most of their outcomes. And then 2/3 of the FFR-guided patients had PCI of their non-culprit lesions. So that portion of patients also was treated similar to the angio-guided. So really there were only 1/3 of patients in the FFR guided group who had a different treatment that might be either better or worse. And so I think the study was underpowered because of that. And this is reflected by the average of 1 versus 1.5 non-culprit stents. So really the degree of treatment was not that different. So when you think of it that way, it's not surprising that the two groups did similarly. In addition, they had no assessment really of peri-procedural MI. That's difficult to assess in a patient with STEMI. But we know that FFR, by avoiding unnecessary stents, avoids unnecessary peri-procedural MI. And so in this study, you couldn't really account for that. So that also may have played a role. So the take-home messages that I have from FLAVOUR MI are that FFR-guided PCI of non-culprit lesions in patients with STEMI leads to similar outcomes compared to with angio-guided PCI. And FFR-guided PCI results in medical treatment of non-culprit disease in about 1/3 of patients. So you can avoid unnecessary stents without any real increase in harm, although you don't have a major benefit. One question that we didn't have from the data so far that I hope will come in a sub-study is what percentage of events that happened during follow-up in the FFR-guided patients were due to deferred lesions versus, say, the culprit, vessel that was stented. I think that'll be really interesting to help us understand better the role of physiology. And I'd like to highlight this other study that out of Korea that looked at almost 300 patients, all with at least one lesion with a moderate stenosis that had CTA and FFR, and then the vulnerable plaque characteristics based on the CTA were correlated with the FFR. And what you see down here is that patients who had high FFR, above 0.90, more than 50% had no high-risk plaque characteristic on their CTA. So there was a correlation with the FFR and CTA. Only 3.5% had, more than 3 high-risk plaque features. And then as your FFR gets lower, you see that the percentage of high-risk plaque features goes way up, so that when you get down to less than 0.60, more than half of patients had 3 or more high-risk plaque characteristics, and 97% had at least 1. So I think this helps explain how physiology, it's able to identify actually vulnerable plaque. And I think that helps explain why treating lesions with low FFR leads to better with PCI or revascularization improves outcomes compared to medical therapy. And one other point I'd like to make, getting back to whether or not physiology is reliable in these non-culprit lesions, comes from this sub-study from the Compare Acute trial. In that trial, they measured FFR in the non-culprit vessels, and they either deferred or treated. And what you see is that the patients who had low FFR, who were untreated, managed medically, had a much worse outcome compared to those with high FFR that were treated medically. So it would argue that physiology still can identify those lesions that are dangerous versus those that are safely treated medically. So in non-culprit vessels of patients with STEMI, FFR may be slightly elevated, and the non-hyperemic pressure ratios like IFR may be slightly reduced, but these changes appear to be minor and in most cases not clinically relevant. And I think coronary pressure-based physiology is still the gold standard for evaluating these non-culprit lesions at the time of ACS. And then just in the last minute, I'll mention that there are a lot of exciting angiography-derived techniques for measuring physiology that have now been developed, and coming up at TCT this fall will be the presentation of the FLAVOUR-3 China trial, which is a really exciting randomized study looking at QFR, one of the angiography-derived physiology techniques, versus angio-guided for guiding PCI. So I look forward to hearing those results. Enrollment was completed, and as I mentioned, it'll be presented this fall. There are techniques for looking at microvascular resistance using these angiography-derived methods that are exciting as well. So sorry if I ran over a little, but thank you for your attention, and happy to take questions.
So thanks, Bill, for the excellent summary and elegant presentation for the overview of the coronary physiology in the current situation. So that any suggestion, any comments and questions to Bill? So in your last part of the slide, you just briefly mentioned the futuristic approach of the image-derived physiological assessment, so that if there's a flavor to China, Europe, Japan, results are ready. How do you feel about the position of invasive physiology? So that will that reduce the number of invasive physiology, or that they will be complementary?
Yeah, that's a great question. I think there are limitations to the image or angio-derived indices. There's certain patients where there's just a lot of overlap of the arteries, no matter what angle angiogram you perform, or the vessels may be particularly calcified, which may limit the analyses. And so I think there's always going to be a role for wire-based techniques, but I do envision that in many cases, these image-derived or angio-derived are going to replace or decrease the need for the wire. I mean, it's just, I think once we have more data like, the FLAVOUR China trial and others that are clinical outcome studies showing, hopefully, non-inferiority or superiority of these techniques, that'll even encourage more use. I think they'll be more, they'll take less time, they'll be less costly and just easier to do.
Thanks.
Can I ask Bill a question as well? Hi, Bill, that was an excellent summary. Where do you see all this headed actually? Because there's still quite a lot of scatter for IFR, FFR. Do you see in the future whether we'll combine some of the plaque characteristic in prospect in imaging into physiology? How do you see these two coming together to make it even more refined? Because there are downsides to both at the moment.
Yeah, no, you're really highlighting a great point, that every test that we have has its limitations, and no test is perfect. And I think you're right, and I think the field is moving in that direction of combining, imaging with physiology, both resting and hyperemic physiology, because both of them have, advantages and disadvantages. And so, for example, there are OCT catheters that may have the capability of measuring, physiology simultaneous with getting imaging. And I know there's other wires that may be able to image and provide physiologic information. So yeah, I think that is the future. And I think there certainly are patients, for example, like in the Prospect 2 study, who have a high FFR, not flow limiting, and they still have events. And how can we best identify those patients and improve their outcomes? And I think imaging will play a key role in that.
Okay, so thanks again for the invitation. So I'd like to talk about the part of my new paradigm after ischemia trial, and there will be some overlap with that Fearon's presentation. We know the ischemia trial very well, and there can be several different interpretations of the results, but as a main outcome, actually, there was no difference in a routine invasive versus conservative treatment for patients with stable coronary artery disease and at least to moderate or severe ischemia. So I know that there are several interpretations and several different stories from that ischemia trial, but I think one thing is true, that the ischemia dogma, actually mainly based on MPI, and which we have been taught from our senior teachers, is in danger, and paradigm maybe needs to be shifted from that ischemia dogma. So in that perspective, I think it's very interesting that the new European guideline for stable coronary syndrome adopt the use of coronary CTA and invasive physiology in the evaluation and treatment strategy for patients with stable coronary artery disease. And practical question is what we can do with the CT or other imaging studies and invasive physiology in the cath lab. So in that perspective, I would like to talk about the outside cath lab story, mainly focusing on CTA, and inside the cath lab story, focusing on invasive physiologic assessment. So like in ischemia trial, in general, we are using CTA for excluding the presence of significant disease, and generally we use this number for the CTA. And when the degree is intermediate or moderate to severe, we generally send the patient to the cath lab. If FFR negative, IFR negative, we say that, okay, there's no ischemia and no need of PCI, we just forget about it. Actually, that's a guideline-directed approach. However, we know that there are several behind stories in these images. We know that there are several different plaque characteristics that can impose the higher risk than those without, and what we call that as high-risk plaque characteristics, such as luminaria, plaque burden, low attenuation, positive remodeling, Neptune ring sign, and spotty calcification. So as we already have these imaging devices, even if the physiology is negative, there's a chance that we can have a better stratification of these patients when we integrate the CTA and the physiology. So in this, from a post-hoc analysis of 3-vessel FFR French study, among all patients with high FFR and deferral or the guideline-directed medical treatment, if the lesion does not have more than 3 or more high-risk plaque characteristics, outcome is really good. But even if high FFR but deferral, if there's 3 or more high-risk plaque characteristics, the event risk is increased almost as 4 times. One very interesting interpretation of this results is that this is the reference, low FFR PCI, and these are the high FFR deferral. So this is the reason why we do not recommend PCI for those lesions, because that the outcome is better even with medical treatment in comparison with this reference. But if the vessel has 3 or more high-risk plaque characteristics, even FFR high under optimal medical treatment, the event rate is numerically higher, so that the combination of these two different information can provide us better risk stratification and may provide us a proper treatment selection for these lesions. So having said that, I'd like to talk about in general, concept of the high-risk plaque characteristics. So we know the physiology is good, and also high global disease burden is a matter, and also the local lesion plaque characteristics and local disease burden. So I would like to talk about how we can combine these to better discriminate the patient risk. So each of these elements as a binary cutoff is important prognostic indicator. So low FFR, high global disease burden, presence of high-risk plaque characteristics, high local disease burden is associated with a higher risk under medical treatment. However, the question is that whether these association between plaque and events, physiology and events, is a simple association, or there's a direct and indirect effect, because that as Bill just showed, that there is association between the FFR and number of high-risk plaque characteristics and vulnerability. And to discriminate that, what we did was that the mediation analysis. So high global disease burden, high-risk plaque, and high local disease burden, in terms of the vocal or the clinical events, there's an indirect effect or the association with the physiology for high global disease burden, high local disease burden. So it's natural that if global disease burden is high, FFR will get low, and there's association with the event, except for high-risk plaque. But there's also a direct effect of all these 3 elements, so that this suggests that the combining of these 2 will provide a better risk prediction. So in other ways, so what it did was that this machine learning technique, when we found a machine learning based high-risk features, there was a ischemia, high global disease burden, high-risk plaque characteristics, high local disease burden all were high-risk features. And the good thing is that if we combine one by one, and if we combine all together as ischemia, high local disease burden, plaque characteristics, and high local disease burden, we can really see that combining all these 4 elements can really provide us the risk of the future event in these patients or vessels. So having said that, one very nice thing is that I just talk about this invasive physiology, but using this non-invasive imaging, we can assess all these 4 different components by the CT scan. And I would like to talk about the other hemodynamics. So we just, while talking about physiology, we generally talk about the FFR, IFR, and other non-hyperemic pressure ratio, but there are several different hemodynamic metrics, so that we are working with this Emerald study, and what we are also working with the Emerald 2 study to define different hemodynamic metrics to better assess the risk of the future cardiovascular events, especially for acute coronary syndrome. So when we divided plaque according to the presence of the anatomical risk or the adverse plaque characteristics and hemodynamic risks, such as adverse hemodynamic characteristics, such as FFR, delta FFR, versus and APS, we found that as a reference of the APC negative, AHC negative, if there's a plaque, either APC positive or AHC positive, the risk of future ACS is around 4 times higher. And if there's a vessel or plaque has both APC and AHC, the risk for ACS, acute coronary syndrome, is increased almost 12 times higher. So that this is hypothesis generating study, but at least is telling us that the combining plaque characteristics, hemodynamics, or anatomy and physiology can provide us better information on this. And in the cath lab, people are sometimes skeptically saying that the FFR is just a diagnostic test or it's just a research tool, but there has been several new studies showing that this from Fearon's group and this from SCAR registry showing that the FFR guided strategy can actually reduce the mortality, which is really important for the patient. Another important part is the post-PCI assessment. So there will be several presentations related to that, but I would like to just briefly mention that in the ischemia trial, it was regarded as an optimal revascularization when there's ischemia and PCI. But we know that even if ischemia-directed PCI, when you assess the physiology after the successful stent implantation, there can be a residual ischemia, so that this optimal revascularization should be assessed by the post-PCI physiological assessment as well. And the good thing is that there are many new ways to predict and planning of the optimal PCI strategy. So this is a very diabetes-like disease from left main to the whole LAD. Sometimes we don't know what to do, whole metal jacket surgery or the medical treatment. But when we apply the recent technology of co-registration with the sync vision device, you see that even it looks anatomically very diseased, there's some physiologically focal disease, and we can estimate that if we put around 30 millimeter stent, we can definitely relieve the ischemia. And finally, I would like to talk about the microvascular dysfunction, FFR negative, but IMR, CFR positive, because that the ischemia trial, in ischemia CKD cohort, actually half of the patients no revascularization because they don't have obstructive disease, even if they have a positive stress test. And in this cohort, there's even no benefit of angina-related health status with the invasive strategy. And I think this is due to the microvascular dysfunction. And we found that the presence of overt microvascular dysfunction is associated with the higher event rate. And in recent analysis of the combined international MCD registry, we found that if the vessel or the patient have high IMR and low CFR, actually the risk for death at MI also increased. So I briefly talk about these outside and inside cath lab for new paradigm after ischemia trial. And I think that the paradigm needs to be shifted or modified. And if we combine all these novel insights into our daily practice, we can definitely improve the prognosis by reducing the hard endpoint. Thank you very much for your kind attention.
Thank you very much for a nice lecture, Dr. Koo. So now it's open to discussion. Is there any questions or comments? So I will start first. So Dr. Koo, you mentioned that the adverse plaque characteristics can predict, even though its FFR is negative, more than 8, still there's a higher chance of event. And also the adding the adverse hemodynamic characteristics really increase the prediction of MACE. And also if we add like a reverse clinical characteristics, we can more prediction about the clinical event. So now is next step is how can we prevent that kind of event with the detection of that kind of various factors. So in clinical situation, how we can approach that kind of a patient.
Yes, I think that's a very important question. So that when I say adding this will give you a better discrimination, and adding that will give you a better discrimination. So the practical question is how much can be added to have a better discrimination, and why we're doing that? It's because that we know that the concept of vulnerability is actually, the issue is that the very low positive predictive value. Its negative predictive value is good, and its positive predictive value is very low, no matter how we assess the vulnerability. So practical question to me is that how I can increase that positive predictability, as current paradigm cannot provide the enough clinically relevant or clinical practical guides. So that's the reason why we are doing that. And while adding some additional point, actually increase the positive predictability, no matter what, it's a local lesion characteristic and whole vascular plaque characteristics, either assessed by the IVUS, OCT, CT, etc. So that's why we are working with that. And another very important thing is that we shouldn't neglect the clinical risk factors. So in your recent elegant paper published in JACC Intervention show that the importance of clinical risk factors for MACE. So if we only analyze the target vascular events, these matters. But if we consider the MACE and hard endpoints, clinical risk factor really matters, so that we have to integrate all those together, but we have to work together how we can do that.
Can I ask a question of Dr. Koo? It was excellent actually, and this is exactly where we should be headed. It's really cutting edge, the stuff you're doing. But putting ischemia and everything into the piece for stable coronary artery disease, where do you see the prediction in terms of what kind of therapy strategies you think then this will help change outcome? Is it prolonged depth, more antithrombotic? Is it a different level of statins, for example? Or is it just truly revascularization of stents? Because I think if you put it together, we don't have a grasp of, after we have this, what is the intervention that you're pitching for that truly change heart outcomes? What are your thoughts on that?
Right, so that I agree that's also another very important question. So that the simple approach for the stable coronary artery disease is giving high-dose statin and the antiplatelet, so finish. But the thing is that even from the Ischemia trial, we found that the spontaneous, if we simply see the spontaneous MI, there is a almost statistically significant difference in reduction of MI in PCI. So that the question is that how we can select the right target for the PCI to improve the patient outcome. So I know that the portion of that part is low. So we cannot say that just vulnerability or the presence of TICFA is a green light for PCI. So that we have to put additional data to really select the
Sorry, I cannot hear the voice.
Okay, is there any other question or comments?
Okay, maybe a very short question for Dr. Koo. Okay.
Okay.
Dr. Koo, where you have questions, you go ahead. Okay.
Okay, very nice talk, Dr. Now we have a lot of several physiology tools like FFR, IFR, QFR, CTFFR. So how do you integrate these physiology tools in your daily practice?
So now, can you hear me?
Yeah.
Okay, great. So that practically I'm measuring both resting and hyperemic indices. And in our recent study that if both are positive, the outcome is really bad, and both are negative, outcome is excellent. And in discordant cases, actually in the short term, outcome is similar to both negative, but in the long term, during 5-year follow-up, outcome was similar with the both positive. So that the presence of having both may be better than leaving one alone to overcome the limitation of each modality.
Thank you for having me. It's very honorable to me. So my topic is post-PCI FFR. Should we measure the after IVUS guided PCI? And this is my conventional thought that IVUS and imaging have a different role for the PCI. The IVUS has a role to decide the revascularization. FFR has a role to decide the revascularization, and IVUS has a role for stent optimization. However, nowadays many interventionists pay attention to the role of post-PCI FFR for the stent optimization. So today, I'd like to raise several issues about the post-stent FFR measurement. What is the best cutoff value, the location of pressure drop, location of clinical events, prognosis of residual diffuse disease. If a post-PCI FFR is very normal, is it optimal, or role of coronary imaging in the stent optimization? It could be somewhat provocative. I'm very welcome to many questions. So first of all, different from the pre-PCI FFR cutoff value, the pre-PCI FFR cutoff value in the previous study usually located between the 0.75 and 0.80, so gradient is very narrow. But compared with the pre-PCI FFR cutoff value, post-stenting FFR cutoff value is very wide based on the previous study. From the 0.79 to 0.96, very wide cutoff value reported before would be understood based on the underlying mechanism of post-PCI FFR. I will explain it later. I think the most important consideration would be the location of pressure drop after PCI. So several studies demonstration the major pressure drop after PCI. Defined PCI study demonstrate that only 38.4% of pressure drop occurred within the stent. So more than 60% of pressure drop occurred outside of the stent. FFR such study demonstrate that only 27% of pressure drop, that means the significant FFR drop occurred within stent. So majority of pressure drop occurred outside of a stent. This study is a post-PCI FFR CT study. Only 13% of pressure drop occurred within stent. So this is another study by the Utreski showed the similar findings. Pressure drop mostly occurred distal to the stent. However, look at the location of events after post-stent FFR is different. This is the instance of stented lesion event. These two studies are done by the Dr. Gu, International Post-PCI FFR Registry, Prospective PCR Registry. Nicely reported that the stent-related event, that is the TLR, is 76.6%. The Prospective PCR Registry stent-related event is 76.9%. So majority of clinical event occurred within stent. This is our registry study. So there should be the mismatch between what we want to predict the clinical event and what we measure the pressure drop. So the pressure drop occurred predominantly outside of a stent, but clinical event occurred within the stent. So how to compromise between the two things could be the important issue for post-PCI FFR measurement. This is another issue. What is the prognosis of residual stenosis outside of a stent? FAME trial nicely demonstrated that the investigators calculated the functional residual syntax score show that the functional registrar score has no prognostic value. However, even in the original anatomical residual syntax score had no prognostic value. This is the first paper by the Philippe Jenner-Roux demonstrated that excluding first 10 days, the residual anatomical, even anatomical residual syntax score had no prognostic value, or things are very parallel. This is Jun Li and Dr. Gu's another papers. Based on these papers, we can assume that what is the meaning of post-PCI FFR? Anatomical residual syntax score calculated outside of stenosis. So when we implanted stent, we don't calculate it. So, but the anatomical residual syntax score had no prognostic value, but in this paper, post-stent FFR has information of both the stented lesion and non-stented lesion, has a prognostic value. So if non-stented lesion event is very low, prognostic value of post-stent FFR is equal to the stented lesion outcomes. So then, if the FFR value is very optimal, post-stent FFR value, for example, more than 0.96, then we can consider it the optimal stent result. Already, Dr. William Fearon nicely reported that FFR value more than 0.96 cannot predict the optimal IVUS cutoff value. Predictive accuracy is only 50%. Flip the coin. Recently, the Just Demon nicely demonstrated and confirmed the previous William Fearon's findings that this paper demonstrated the mechanism of post-PCI FFR less than 0.85, but I like to focus on the mechanism of more than FFR more than 0.85. Look at patient number is only 20%, but even though FFR post-PCI FFR is more than 0.85, suboptimal stenting defined by intracoronary imaging is up to 90%. Focal lesion, under expansion, lumen compromised hematoma, malposition, 90%. So the good post-FFR value cannot guarantee the optimal stent result based on the intracoronary imaging. It's very similar to the IVUS findings. Previous ADAPT-DS study demonstrate that after a successful angiographic guided PCI, if you do the IVUS, 74% of procedure can be changed because of additional procedure, larger size of stent, high pressure, long stent, etc., etc. Then, in case of a low FFR, low post-PCI FFR, what is the next? Interesting groups nicely demonstration that additional procedure based on the low FFR can improve the final FFR. But in this study, the intracoronary imaging used only 9%. Recently, we observed the result of a target FFR study. Target FFR study is randomized compared to the physiologic guided optimal stent strategy and standard treatment. But they failed to show the difference between the physiologic guided stent optimization and control group to achieve the final FFR more than 0.90, no statistical significance. But I was surprised to see the in detail procedural characteristics. Intravascular imaging, they used only 16%. Only 1/3 of a patient had an optimal stent strategy applied. Why intracoronary imaging is important? Previously, we demonstrated that the intracoronary imaging guided PSP technique can improve the patient outcomes. We categorized the many scenario with the pre-dilatation, no pre-dilatation, with IVUS, no IVUS, post-dilatation, no post-dilatation. Scenario 4, no IVUS guidance, compare with this scenario 7-8 show that the IVUS-guided additional post-dilatation, larger stent diameter, and compared with the stent diameters, final post-balloon size is bigger than by 0.3. One size, we can use the one size bigger stent. So this is very effective. It could be an effective post-dilatation resulting in improved patient outcomes. So final issue is if we apply the IVUS-guided PCI, do we register data? From our registry, we enrolled 1,000 patients, 300 lesions received IPSP, optimized stenting strategy, and 700 lesions did not have received the IPSP optimized stent strategy. This is independent correlate for post-stenting FFR value, overall population, male sex, left main LAD location, stent diameters, stent length is associated with the post-stent FFR value. Imaging-guided PSP group, proximal location, and stent length is associated with the post-stent FFR value. So after IVUS-guided PCI, optimized stent strategy, diffuse stent narrowing would be associated with the low FFR value. But no IVUS-guided, imaging-guided PSP group, the most significant correlate for the post-stent FFR was the stent diameter, not stent length. So it can be interpreted as that the under-expansion could be the most important correlate for the post-stent FFR. So this is the overall population based on the ROC curve analysis. The cutoff value was 0.86. There was a significant difference between the post-stent FFR less than 0.86, more than 0.86. But we categorized into two groups: imaging-guided PSP group, non-imaging-guided PSP group. So look at no imaging-guided PSP group. The AUC is significant. I'm sorry, it is reversed. Imaging-guided PSP group, so AUC is progressive value is insignificant. The imaging-guided PSP group, the best cutoff value is 0.83, no difference above the 0.83. Non-imaging-guided PSP group, according to post-PCI FFR value, there is a significant difference regarding the clinical outcomes. This is the estimated risk of clinical event and post-stent FFR according to the IPSP. So the imaging-guided PSP group, there is no difference regarding the post-PCI FFR. However, the non-imaging-guided PSP groups, high post-FFR clinical outcome was good, low post-PCI FFR clinical outcome is bad. So the interaction was very significant. This is independent predictor, overall population. Interaction was significant. This is very interesting. Imaging-guided PSP groups, we cannot find the independent non-imaging guided PSP group. Stent diameter was a very significant predictor for target vessel failure, and post-PCI FFR was a significant predictor for the target vessel failure. This is a summary of our observation. Significant prognostic interaction between the post-stent FFR and performing the imaging-guided optimized stenting strategy. Post-stenting FFR was responsible for the target vessel failure at 5 years in lesions treated by suboptimal stenting strategy. For example, angio-guided PCI, while there was no association between the post-stent FFR and the risk of TVF when optimized stenting strategy, that is imaging-guided pre-dilatation, stenting. But after the IVUS-guided, CAG-guided PCI, low post-stenting FFR based on the prognostic value leads to the intracoronary imaging to evaluate a suboptimal stent and correct it by additional procedure. However, if we perform the imaging-guided optimized stent strategy, post-stent FFR did not show the prognostic value and thus did not to measure it. So this is my first question. Should we measure the post-stenting FFR after IVUS, not directly by post-stenting FFR value, but upfronting intracoronary imaging should be used for stent optimization to improve the patient outcome? Then when post-stenting FFR is necessary, I think two cases, side branch. After crossover, there is a tight side branch. If we want to treat more lesion above the 0.80, in addition, tandem lesion, there is a two lesion, FFR, post-stent FFR would be a good tool to decide the stent to implant another stent or not. Thank you for your attention.
Thank you, Dr. Ahn. A very nice lecture. So now we're open to discussion or comment. Is there any comments? Okay, I will do first. So Dr. Ahn, you mentioned that the imaging guidance, if we do the imaging guidance, we don't need to measure the FFR. But if we start with FFR pre-interventional evaluation, then how about your opinion? Do we need to measure post-PCI FFR before use of IVUS, or you always do the IVUS or IVUS with FFR guidance both simultaneously? It didn't make too much medical cost. That is another issue. So when we start with the pre-interventional evaluation by FFR, then what we can approach the after PCI?
So thank you, very important questions. But I think after procedure, I don't like post-PCI FFR did not provide the additional information. I think the IVUS or intracoronary imaging is more important, because if FFR is low, we have to do IVUS or OCT. If FFR is high, we cannot guarantee the optimal imaging guided stent result. So in any case, the FFR value cannot predict the optimal stent result. So I prefer the intracoronary imaging after stent implantation, even though I already measured the pre-PCI FFR value. But more important, so far we don't have any information, but if we have further data about the pre-PCI FFR pullback information, it can be associated, it can modify our stent strategy. I don't know this data is not available nowadays, but if we will have such a data, I will change my mind. But so far, I will measure the IVUS instead of FFR after stenting.
So I think this is a very interesting and somehow provocative, but a very important study. So that I think that what we found in our another analysis was that in patient with the very low pre-PCI FFR, the half of events occurred in the non-target lesion, so that it's a non-TNR TVR. So that if we simply add up with the moderate or the mild stenosis or the mild ischemia, I think that I agree that your opinion is okay. But if the pre-FFR lesion FFR is very low, I think there should be some value, because most events occurred in the non-target lesion. At least half of the lesion occurred in non-target lesion. And when we recently combined all the data post-stent FFR, actually in the very large number of cases, there was a prognosis implication of post-stent FFR regardless of use of IVUS. So that I agree that your concept is in part adequate. The question is whether the disease is it's focal or the diffuse, so that that may need to further clarification in further studies. But I think this your concept is basically adequate, and will give us giving us a very important insight in analyzing and interpreting the post-PCI physiology.
Thank you thank you, Dr. Guo. Very nice. Thank you for very nice comment. But I think if what is the case if the pre-PCI FFR is very low? Because I think there should be definitely there should be some lesion, another lesion outside of a stent. I think so. That's why it caused the future event. There should be some reason why we didn't treat the outside of a stent title lesion. So it could be some bias in some or tandem lesion in the distal. I think in such a case, we may have a very low FFR value. So instead of post-PCI FFR evaluation, I think a pre-PCI stent design would be more important than post-PCI FFR value.
Sorry about the trouble. So my talk is a role of post-PCI FFR, very similar with Dr. Ahn's presentation, but I will little focus on the clinical practice. So in our daily practice, we use the FFR as a great surrogate marker for ischemia. So we prepare the pre-interventional evaluation whether there is ischemia or not, and do the follow-up the FFR value as a PCI if FFR is lower than 8.0. So in this case, intermediate to mid RAD and the tight proximal RAD, and the FFR value was 0.62, and most pressure stable was developed in proximal RAD, and then put the one stent in proximal RAD, but still FFR value is low. So after stenting, measurement of FFR is a kind of a physiology gain of treated vessel. But the vessel after stenting of a coronary region, the post-PCI FFR value can be very various. So sometimes very close to 1.0, sometimes very low, so lesser than 0.80. So in very different scenario can be happened after PCI FFR measurement. So we don't know the optimal cutoff value of post-PCI FFR. So previously in bare metal stent era, the best cutoff was 0.90, and then when you use the first generation DES, my study showed also same FFR value 0.90 was the best cutoff to predict clinical outcome. However, after that study, so many studies was published, but every study had a different cutoff value. Because that's why the Dr. Ahn said that the post-PCI FFR measurement can be valuable. But I may say the optimal cutoff value of a post-PCI FFR can be changed by the study population and type of stent and endpoint and included vessel. So just a higher post-PCI FFR was associated better clinical outcome. So just the relationship between clinical outcome after PCI and post-PCI FFR value was confirmed. So in this case, so after proximal RAD stenting, still FFR value is low. In that case, we can say that because it's lesser than 8.0, we can treat with additional stenting in mid RAD, and the final FFR value was quite acceptable. However, if FFR value is more than 8.0, in this case, how can we what should we do next step? Actually, in this case, mid RCA has tight stenosis and the diffuse proximal RCA and distal RCA region. So pre-stent FFR value was 0.70, and then we put stent mid RCA with one stent. After stenting, we can detect the value of 0.83. But we have to remember not only just the number of 83, but also we can check with a pullback analysis trans-stent pressure gradient. And also we have to compare the pre-interventional FFR value and the post-PCI FFR value also. So first, trans-stent pressure gradient is very important because as Dr. Ahn mentioned that even though we measured FFR, but there can be something inside of stent. So high trans-stent pressure gradient can be a useful predictor or indicator of suboptimal result, such as underexpansion or edge dissection. So if you measure the post-PCI FFR, especially you can detect when you detect high trans-stent pressure gradient, it means we need additional procedure or additional evaluation using EVG device. And also not only in trans-stent pressure gradient or in-stent pressure gradient, but also we have to concern about the residual non-target lesion disease. Therefore, Dr. Gu and Dr. Ri do the very elegant study, not only absolute gain of FFR, just the post-PCI FFR value, but also the percent increase of a pre and post PCI. So if the percent FFR increase more than 15%, their outcome will be very good. So if you merge the absolute gain and the relative gain, so if the patient have a very low post PCI FFR or very low percent increase, their outcome will be very poor. But if the post-PCI FFR is very high, and also the percent FFR increasement is enough, their outcome will be very good. So we can use the post-PCI FFR measurement to predict the clinical outcome. So in this case, how can we interpret our procedure? First, trans-stent pressure gradient was 3. So it means kind of a very low trans-stent pressure gradient. It can be an indicator of successful stenting treatment. And also, how about the percent increasement, pre and post? High FFR percent increase can be an indicator of optimal PCI result. And how about the number, very low FFR value, final 0.83? Low final FFR value can be an indicator of residual disease burden, not indicator for additional procedure, but we have to focus on for the aggressive medical therapy in that kind of patient. So I may say the trans-stent pressure gradient and the relative gain is very important when you measure the post-PCI FFR. And another post-PCI FFR measurement is a side branch, jailed side branch FFR measurement. So when you meet the bifurcation region, this kind of bifurcation, non-left main bifurcation region, we usually provisional approach to the simple crossover stenting, and then we frequently find the jailed side branch osteum. And Dr. Gu or Dr. Ahn already do the great study. So there is a anatomic and functional discrepancy in jailed side branch. And even though we open that kind of a side branch, we cannot make a better outcome in, with a complex additional procedure. But the non-left main bifurcation side branch is not a big deal because the territory is very small. However, how about the in circumflex left main bifurcation? In this aerated osteal disease, you may try to with one stent simple crossover stenting and pop. The final result was like this. Even though left main and aerated quite acceptable, but the ostium of circumflex a little bit jailed after simple crossover stenting. Current EBC consensus or recommendation, just kissing, pot, kissing, repot. But if you measure the FFR, FFR is high. In that case, even though we treat with medical therapy, until 5 years, their outcome is quite acceptable. If FFR is low in just this kind of jailed circumflex, their outcome will be very poor. In that case, we have to do additional complex procedure. So current practice by EBC guideline, just a simple crossover stenting with additional complex procedure, pot, kissing, repot, and medical therapy. But if we follow the FFR guidance, just the simple crossover stenting and with pot and measure the side branch FFR, if FFR is high, just medical therapy without additional complex procedure. But if FFR is low, we have to do additional procedure. So FFR guidance for compromised side branch after main vessel stenting will reduce the unnecessary complex procedure. The final indication of a physiology post-stent FFR measurement is a kind of a functional concept. Dr. Ahn mentioned that that is not clinical beneficial, but some studies showed a different result. Previously, I introduced the combined anatomic and physiologic scoring system as a functional syntax score is a pre-intervention evaluation. So functional syntax score can lead classification of a patient risk and then better clinical discrimination prediction. Similar concept can be applied after stenting. So residual functional syntax score concept. So if number is high, it means that we do not do the functional incomplete revascularization. In that case, the MACE rate is relatively high. Not only just the MACE, but also death MI rate increase in incomplete functional revascularization patient. So combined anatomy and physiology scoring system after PCI, like a residual functional syntax score, discriminate the risk of adverse event better than just anatomic or just the physiological assessment alone. So ladies and gentlemen, this is my summary slide. Post-PCI FFR is an indicator for physiologic gain of treated coronary artery and related with clinical outcome. And also, the absolute and relative FFR gain can be a good indicator of optimal PCI result. So we can follow that kind of a procedure. And also, FFR in compromised side branch can reduce the unnecessary complex bifurcation procedure. And combined anatomic and physiology scoring system after PCI can better discriminate the risk of adverse event. Thank you very much for your kind attention.
So thank you, Dr. Nam. So now this topic is open for discussion. So Dr. Ahn, do you have any comments for this talk?
Thank you. Thank you.
Yeah, I fully agree with the Dr. Nam's presentation.
Can you hear me, Dr. Nan?
Yes, please.
Hi, Dr. Nan. Wonderful presentation. I have just one short question. How do you measure the delta FFR? You know, for some kind of lesion with diffuse disease, it's very hard to measure the delta FFR. The from the distal part to the proximal part of the vessel is gradually changing. Mm-hmm. So how do you calculate the delta?
Actually, that is a very important point. So when you measure the FFR, there sometimes it kind of a merge of mixed of focal and the diffuse disease. In that case, we have to understand the angiographic finding. So sometimes we have to stop some point and then wait for the FFR value and then move to proximal part and then stop again, and then we can see within 2 points the difference of FFR, delta FFR can be detected. In that, that's a way to how to understand the physiologic change of a coronary lesion. But it's a kind of a little bit tricky, especially in diffuse disease. In that case, sometimes we cannot find out the stent of the segment. In that case, sometimes we need the imaging guidance. So as Dr. Ahn mentioned, that I think in our daily practice, in my opinion, if we start with FFR guidance pre-interventional, then after stenting, you measure the FFR after PCI. Then if FFR value is high enough, in that case, we don't need to evaluate again with another imaging device. But if the post-PCI FFR value is lesser than your expectation, in that case, especially in the inside of a stent, trans-stent gradient is high. In that case, I think imaging guidance is very helpful to prevent the patient adverse outcome.
I have one question to Dr. Nam. So how to compromise, I think it could be contradictory. How to compromise both the FFR improvement and post-PCI FFR has the prognostic value.
What the
I mean if the post-PCI FFR improvement is very good, even though the post-PCI FFR is very low, patient outcome was good. So, but according to the 4 different groups, only patients with low post-PCI FFR improvement with low post-PCI FFR value, that group only have the worst clinical outcome. Other 3 groups has similar good prognosis.
Yeah.
So how to compromise to me, it could be a contradictory between the low post PCI. So how to compromise the two different findings?
Yeah, actually, we mentioned that the disease severity is not only just focal, but also the diffuse severity of disease. So if there is a residual disease, in that case, we cannot get the high post-PCI FFR value. In that case, we have to concern about whether we can get enough percent increasement. And in that case, if we can get the high post-PCI FFR value or high percent increasement, that in those cases, PCI will be very beneficial. So in that case, we have to see the pre-intervention FFR measurement. We have to see the focal pressure step up. If there is enough focal pressure step up, even though it's very FFR or very low FFR value, we can approach with revascularization therapy like a stenting. But if there is no very low FFR value and then there is no focal pressure step up, in that case, it is very hard to improve the post-PCI FFR and the percent increase. In that case, it's not indication for the revascularization by stenting.
Thank you.
Dr. Nam.
Yep.
Yeah, very nice talk. From the Dr. Ann's talk, he suggests use images to guide the stent optimization. So do you think we can use FFR pullback to predict the IVUS results? Because in the daily practice, a few patients can pay the cost for both IVUS and FFR.
Yes, I totally agree. The issue is cost. If we can neglect the cost, we have to use the both of the system, FFR and imaging guidance, to improve patient outcome. But if we have only a choice of a physiology guidance, we have to measure the post-PCI FFR measurement, and then if we find out the instant pressure step up more than 4 or 5, it means there are high chance of under expansion or active complication. In those cases, we have to do additional evaluation. But if instant or transstant pressure gradient lesser than that number, in usual practice, we don't need to additional evaluation in those patients.
So I think this area needs more research, and we have to understand the limitation of each modality. And one thing I have to say is that for the post-PCI delta FFR cross-stent, its negative predictive value is low. So even if it's good, but it does not always guarantee the success of stent, and that's why Dr. Ahn stressed the importance of imaging, so we need further data in this issue.
Okay. Thank you for all of you to join JACC Asia webinar series, Coronary Physiology Update. So I'm going to deliver my presentation. I'm going to introduce the FLAVOUR and the FLAVOUR 2 studies. My content is going to cover the 4 topics. First, I will introduce you the background. Actually, I don't think I need to take time to introduce the background. Like so many speakers today, you already provide strong evidence to support the FFR guided PCI strategy has a significantly meaningful than the angiography guided PCI to have a best outcome. This is actually the study we work with Dr. Koo. This is a subgroup analysis. So among this patient with deferred PCI procedure, for this patient with FFR larger than 0.8, have much better outcome than those patients with FFR lower or equal 0.8. So what is about the IVUS guided PCI strategy? Still, we have so many evidence to support the IVUS guided PCI strategy. Provide the patients better outcome for than the angiography guided PCI, especially for those patients with left main diseases. So here is some evidence, like the ADAPT-DES study. So compare with angiography guided, IVUS guided PCI, significantly decreased the MACE by 33%. So both in complex and STEMI patients. So FFR and IVUS, as we know, the FFR is a kind of the functional evaluation. However, IVUS is an imaging evaluation. So both of them are nice tools. Then which should we select or prefer? So that's why we carried on. Actually, we work with the Dr. Koo. Actually, he always contribute a lot the original thinking for the FLAVOUR study and the FLAVOUR-2 study. So what is the rationale for IVUS versus FFR? Maybe FFR and IVUS are not antagonistic, but rather than cooperative elements or cooperative parameters. So can these two be compared? So I think we actually Dr. Koo and Dr. Koo's team and my team, we worked together for a long time. So we think we still need a comparison of these two methods, because first, so these two strategies are commonly used method in selecting the patients who need a PCI and to optimize PCI. And no previous direct head-to-head randomized comparison of the two strategies in terms of clinic outcome and clinical relevance. So we can determine which is more important. So selecting who to treat versus selecting how to treat. So the two parameters are not conflict. So they may work together for achieving better outcome for our patients. So the whole title of FLAVOUR study is Fractional Flow Reserve and Intravascular Ultrasound for China Outcomes in Patients with Intermediate Stenosis. The primary object is to compare the efficacy of FFR guided PCI strategy with IVUS guided. So in patients with intermediate coronary stenosis. So the working hypothesis is FFR guided PCI strategy will show non-inferior rate of patients-oriented composite outcome, POC, at 2 years after randomization compared with the IVUS guided PCI strategy. Dr. Koo and Dr. Tak and I, so 3 of us work as a principal PI. Totally, there are 18 centers included for the clinical trial. So 11 in China and other 7 in Southern in Korea. This is the study design. It is a prospective randomized international multicenter trial. Patient with intermediate stenosis. So the stenosis rate is distributed from 40 to 70% by visual estimation at the proximal and the middle part of major epicardial coronary artery. Randomization is carried on by 1-to-1 to FFR guided versus IVUS guided strategy. Here's the inclusion criteria. Age need to be over or equal 18 years. Suspected ischemic heart disease, de novo proximal to middle second coronary lesion in a major coronary artery, So target vessel size need to over 2.5 millimeter by visual estimation. So intermediate stenosis, 40 to 70% of stenosis rate. So on my right side is exclusion criteria. So because of time limitation, I don't want to go one by one. The PCI criteria in the FFR guided group is FFR. The criteria for revascularization is FFR less or equal 0.8 after hyperemia induction. In the IVUS guided strategy, the criteria for PCI is minimum lumen area, MLA less or equal 3.3 millimeter square, or MLA 3 to 4 meter square plus plaque burden larger than 70%. What is about the PCI optimization definition? For FFR guided strategy, the post PCI FFR is need to be larger or equal to 0.88, or post PCI delta FFR less than 0.05. So for IVUS guided strategy, PCI optimization need to be plaque burden at the standard edge less than or equal 55%. MSA larger or equal 5.5 millimeter square, or MSA larger or equal distal reference lumen area. So here's the primary endpoint. Primary endpoint is a patient-oriented composite outcome at 2 years. All-cause mortality, myocardial infarction, including pre-procedure MR. So repeat the revascularization, put them together. So I don't want to talk more about the second endpoint. Follow up the points is post-procedure at 1 month, at 12 months, and at 2 years. The sample size from calculation, we calculate the sample size. So we enrolled 1,700 patients. So randomly divided the 2 groups. So one is for the FFR guided strategy, the other 850 is for the IVUS guided strategy. Totally, we enrolled more than 900 patients from China and almost 800 patients from Korea. We already finished the enrollment. I think at the end of November of the year, we will finish all of the follow-up. End of the August of this year. So now I'm going to talk a little bit about the FLAVOUR 2 studies. I think all of we understand. So first, I would like to introduce you the QFR. What is the QFR? QFR is the integration of 3D reconstruction with a modified fluid count. It's a FFR-derived parameters. So already there are several evidence studies to support the QFR guided PCI procedure better than the angiography guided PCI procedure. So we, following the FLAVOUR, we designed a FLAVOUR 2 study. We just compare the, so in FLAVOUR 2 trial, so we just use the angiography, we just use the QFR instead of the FFR to compare with the IVUS guided PCI procedure. Also, we work with Dr. Koo and so many centers coming from both countries. Totally, we are going to enroll 1,834 patients with a coronary artery disease. Will be randomly assigned to two groups. So one is for the angiography-derived FFR guided strategy. The other is for the intravascular ultrasound guided strategy. On my left is an inclusion criteria, which is quite similar to the FLAVOUR 1 study. On my right side is exclusion criteria. Here's the primary outcome. It's also similar to the FFR FLAVOUR 1. So it's the primary outcome still the patient-oriented composite outcome. So including all-cause mortality, myocardial infarction, or any revascularization at 1 year after randomization according to the ARC definition. Now it's time for me to summarize my presentation. A functional test and all intravascular imaging will be the future of a coronary intervention. The series of FLAVOUR study will answer the question, will provide more evidence to support these two important parameters. So the result will come soon. Thank you very much for your attention.
Thank you, Dr. Wang, for sharing the preliminary data and the perspective of FLAVOUR-2 study. So any questions, comments for Dr. Wang's presentation?
Thank you, Dr. Wang. I'm very expecting the result of FLAVOUR-1-2 study. I have one question about the definition of a pre-procedural MI, because regarding the treatment, I was treated population may have a higher rate of pre-procedural MI. So it could be very important to compare to strategy. So what is the definition of pre-procedural MI in both the study?
Actually, in our study, we don't have the MI patient be enrolled. May I understand something wrong with your question?
So the definition of peri-procedural MI in the study.
Peri-procedure MI or peri-procedure.
Yeah.
MI, peri-procedure MI is during the procedure. It's very, actually we don't have many patients for the peri-procedure MI. Hi, Dr. Hu, would you give some idea about the definition?
Yes, I think that's a very important comments for this kind of study. And you know that recently there has been huge issues related to the definition of peri-procedure MI, so that we changed our protocol according to the recent debates, so that we are using from very conservative to the very restricted criteria for the peri-procedure MI, so that in primary endpoint we have a reference ARC definition peri-procedure MI, but for the secondary analysis we will include the ischemia definition and other several different definitions. But as mentioned by Dr. Wang, as this includes a intermediate lesion, there's not many cases with very high troponin or CKMB elevation, but I think that's a very important issue to be raised.
Thank you.
Thank you.
Now,
我今天给大家分享的题目是在 PCI 术中冠脉生理学评价的状态。刚才呢，我们前边的几位教授呢，其实就于这个 PCI 术中或者是冠心病的诊疗过程当中。
So in my presentation, I will talk about the coronary physiological assessment in PCI, the current status. So how can I go forward with my slide? So anyone who could help me? Okay, now it looks good. Okay. The concept is very clear. Why we are going to do the functional assessment? Because we want to understand the relation between the function and the lesion. You know, angiography will show that 70% or 90%. These are the lines, these are the evaluations of the angiogram. However, sometimes we can't simply link the radiology or angio with the symptoms. However, you know, PCI is never a harmless procedure. PCI may have iatrogenic instability on the plaque, and also for the benign lesions, we are not pretty sure if we're going to put a stent there. So that's why in the clinical practice, we do need something like a FFR to understand which lesion to intervene and which lesion not. So that's why we believe that FFR is a kind of well-recognized indicator, and the functional loss of FFR will reflect the function of those major vessels in the epicardium. So here you can see these are the roles of FFR. Firstly, FFR will help us to develop our strategy. And in our clinical practice, for example, the first study showed that FFR negative lesions do not benefit from a PCI treatment. And also in other studies, FFR positive lesions can induce SCS in the short term. We need to have emergent revascularization for that. And also post-PCI FFR, the restoration of FFR will have close relationship with the patient outcome. And also we understand that FFR is also associated with some economical value. So that's why when we are determining the necessity of a PCI, FFR will be helpful to us. So in the clinical practice, if we use FFR to guide the PCI, or if we use the angio to guide our PCI, we may answer some questions. So this is the disclaimer study. So it shows that the PCI does not improve the patient outcome on top of the medical treatment. However, if you use the FFR to guide the patient for ACS or for stable anginas, FFR will tell us which patient to intervene, and the MACE rate will be reduced. And have a look at the myocardial infarction. It looks that compared with medical therapy, FFR-guided PCI will show its benefit versus medical treatment. So in this study, although very small in size, if a pre-PCI FFR is lower and the FFR gain is higher, or if the patient's symptoms are more severe, we can have a better benefit. So it shows that such kind of functional evaluation like FFR will pick up the right patients from the stable angina population, and then we can understand which to intervene, which not. So you can see that this is a prognostic value. We can see that FFR is closely associated with the long-term prognosis. And this is another study among ACS. If we use a FFR to guide which kind of vessel we should have from the revascularization, you can see that compared from simply treating the appropriate vessel, if we use the FFR to screen the patient vessel, we can find out more targeted vessels to intervene. However, there are some controversies on that. FFR will also change our treatment strategy. We will make the strategy more precise. This is a registration study in France, including more than 1,000 patients. So if we take the angio guided therapy, you can see that there are a lot of patients who receive the improper treatment. Here you can see that if we can do FFR, 20% of the patients who are supposed to receive medical treatment based on the angio evaluation should receive the intervention or PCI. So FFR can find out those kind of patients who need or who do not need the PCI. So you can see that it is more sensitive and more reliable than the angio only strategy. So FFR can help us to evaluate the immediate effect after PCI. Just now we had a very good discussion, which is the cutoff line for FFR, and also FFR is closely associated with the prognosis. This is definitely true. FFR is closely associated with the patient's prognosis. And how to achieve a good target value and how to find out the target. Here you can see this is a study enrolling patients from 1995 to 2015. So you can see that the line is 0.9. If the post-PCI FFR is higher than 0.9, the MACE and other endpoints are much more improved. And you can see if we can't restore to 0.9, for example, 0.84. If you take 0.84 as the cutoff line, it's also predictive. And also the FFR increase, 15% or higher than 15% or lower than 15%. You can see that all proves that the FFR is associated with the outcome. So this study only focused on the PCI segment. That means the segment with the stent there. However, for the patient with a residue lesion, we don't know what's happening to that based on this study. You can see that all patients had a very good radiology or angio results. They are all good if you evaluate with some angio. However, if you use FFR to further screen the patient, you can see that about 1/3 of the patient is in the range of 0.81 to 0.89, and another almost 1/3 of the patient has a FFR lower than 0.8. Just 32% of the patient have FFR more than 0.9. So if we do a further optimization, we will increase the percentage of FFR higher than 0.9. But this study does not show the statistical significance. And for the patient with a final FFR lower than 0.8, with the optimization, we can reduce the patient. We can reduce the percentage of the patient with some FFR lower than 0.8. And in this group of patients, we see statistical difference. So it looks that if the FFR is always low with the optimization, it is a sign that the patient has a diffuse disease, and you need to think about more strategies to deal with that. So I think that there are a lot of good indicators based on FFR. For example, we have no guide wire FFR and also other evaluations. And some of the evaluations are now applied in the clinical practice. So they are highly valuable in diagnosis. And also you can see that all those kind of measurement take 0.89 as the cutoff line so that we can combine the different things together. And in the clinical practice, we have proven that IFR and FFR had a very good inferiority. However, it is more straightforward and we can use that in the clinical practice. And also we are expanding the application and indication of those evaluations. We will firstly do some prediction, for example, the functional restoration with a PCI. And we use IFR pullback curve. We will find that if IFR restore to 0.9 and the IFR pullback is 0.92. So these two techniques are highly consistent with each other. And now we can do FFR based on coronary imaging. We want to put everything together, for example, radiology together with some functional, for example, QFR by Professor Wang. And also we have the functional evaluation based on IVUS or based on ICT. And also in the outpatient clinic, we can also do a CT-based evaluation. And you can see this is a FLAVOUR 2 and FLAVOUR 3. They are unblinded, and we are waiting for the result, FLAVOUR 3. So you can see this is a study comparing QFR versus angiography. We believe that in the future we will have a very good result published. And this is an OCT-derived virtual FFR. It has a very good correlation with the FFR. We can improve the predictive value. We can increase the accuracy of OCT. And UFR, which is IVUS-based, also has a very good result. So the summary is that in the clinical practice, we see a lot of functional evaluations which are used in the clinical practice. And from the point of view of accuracy, I think that the functional evaluation, if combined, has much higher accuracy than any single technique. However, if you do functional evaluation, it's more invasive, and maybe you can do some adenosine independent techniques, and also we start from the simple patients, and also we will guide the optimization intraoperatively to get the best long-term outcome, so that in the for the patients with critical disease, for example, whatever branch you are in or the orifice lesions, we can find it's useful, and also it has a very good role in the diffuse patients. Of course, there are some application in the ACS patients. However, we still want to find out the best indicator for the different indications. So this area is very promising, and we hope that we can help the patients to solve the problems in the future. Thank you.
Okay, thank you very much, Dr. Guo. Very nice overview and summary. So any comments or questions to Dr. Guo? So I will ask first, Dr. Guo, QFR already available in China. So in your daily practice, how will you choose the physiology tools? You will choose QFR first, or choose FFR or IVUS first, or what patient will you use QFR? What kind of patient will you choose FFR first?
好，非常感谢胡教授这样一个很好的一个有临床使用价值的一个问题。
Thank you. This is a very good question. I think that QFR is more straightforward in the clinical practice. And according to our early phase study, QFR is highly consistent with FFR. Of course, we still don't know the long-term data of QFR, but it looks that it will be very good. So in the clinical practice, if the lesion is pretty straightforward, for example, single vessel or the proximal segment, and the lesion is not complicated in morphology, I believe that in those kind of straightforward cases, QFR must be inferior to FFR. And also, for the multi-vessel and for bifurcation, we believe that QFR will be more accurate in these areas, but so far now we are not using QFR for those kind of tricky positions. Anyway, FFR is still the golden standard, because all the measurements actually are based on the FFR, and all the studies are conducted comparing to FFR. So that's why I think FFR is still the golden standard, in particular for some complicated, complex cases like the lesions of the orifice and the multi-vessel or the complex or diffuse lesion, FFR will be better. For the straightforward lesion, simple lesion, and also I will do some running dependent evaluation or do something like a QFR. So this is my initial understanding.
Thank you, Dr. Wang. So thanks again for the nice introduction. So I'm again Chang-Wook Nam from Gaming University, Dongsan Hospital in Korea. It's really a great honor to have chance to publish my data in first issue of JACC Asia. So my title is 5-year outcome of simple crossover stenting coronary bifurcation region compared with the side branch opening. These are my disclosure. So in daily hour practice, we frequently met the various complexity of a bifurcation region. And some case, like this 3 case, is definitely complex bifurcation region and definitely need to stent complex procedure. But most of our daily practice, bifurcation region is a very like simple bifurcation region, and then we can approach first provisional approach. When we do the provisional approach, first, the issue is whether we treat the side branch after one stent crossover stenting. As I already show you this slide in previous session, in non-bifurcation region, Dr. Gu and Dr. Ahn showed a very important paper. So there is a, after simple crossover stent, side branch, non-left main side branch, ostium jailed, but there is anatomic and functional discrepancy. So even though it looks like jailed, but the FFR value is okay. So we don't need to open. Even though we open that kind of jailed side branch, their outcome was not improved by the side branch opening. But issue is whether that kind of concept can be applied in left main bifurcation in jailed circumflex. I also showed that even though it's a very small study, but there is still there is a discrepancy between anatomy and function, even in left main bifurcation. And also, if you follow the FFR guidance, it's quite acceptable. However, those studies are very provocative and a small sample size. But in a real-world registry, there is some controversy outcome. So after one stent technique, and then whether open side branch good or not. So some studies showed bad with opening. Some studies showed good with side branch opening. So we don't have a clear answer about that kind of issue. That's why we do this study. The aim of the current study was to evaluate the long-term clinical outcome according to side branch opening procedure of a bifurcation lesion after one stent crossover technique with using a second-generation DES from COVID-3 registry. COVID-3 registry is a retrospective multi-center observational real-world study. It was performed between 2010 to 2014 and include total number 2,648 patients from the 21 centers in Korea. I'd like to show the study flow chart. So I already mentioned the COVID-3 is a second generation DS using, and then we exclude the 2 stent strategies patient. So the included number of patients was 2,194 patients with PCI in using the 1 stent strategy, including left main bifurcation 682 patients. And we divide the patient as just a simple crossover without side branch opening, and then using side branch opening technique like just side branch balloon and pot, or kissing balloon and etc. Various side branch opening technique. And then check the primary clinical outcome as a 5-year target lesion failure as a composite endpoint of a cardiac death and target vessel MR and target lesion revascularization. In the baseline characteristics, the age was early 60, and then within 2 groups, there was not significant difference in baseline characteristics. Only the significant difference was ejection fraction number, but still is a quite acceptable ejection fraction between 2 groups. And also in terms of medical therapy, very similar, but the instance of beta blocker usage was higher in simple crossover stenting. In terms of region location, as you can easily expect, the side branch opening group has higher instance of left main and the array division. And also the true bifurcation instance was a side branch group, opening group has a 58%, and then simple crossover stenting is 36%. The stand number is a little bit higher in simple crossover stenting group because the lesion length is a little bit longer. And in terms of a QCA, the lateral spacer diameter was a little bit larger in side branch opening group, and then disease burden also larger in side branch opening group. It's a real world registry data, so usually is there if there is a more disease in side branch, it's a higher chance of a side branch opening. But the lesion length is longer in side branch group is 5.2 millimeter, but still is very short segment. So if side branch is long, have a long lesion, maybe the patient will defer to the two-stent strategy. That's why this study, even though side branch opening group has a true bifurcation and large plaque, more plaque burden, but still is very short segment and kind of a very soft true bifurcation is included in side branch opening group. After procedure, definitely side branch opening group has a better angiographic outcome, lesser diameter stenosis and a larger minimal lumen diameter. And in terms of kissing balloon technique, is nearly 77% was performed in side branch, and then the other complex procedure was performed in side branch opening group. And the instance of proximal optimization technique part was around 29% in both groups, no difference. And the UCG of IVUS is a little bit higher in side branch opening group because kind of a complex procedure guided by IVUS. This is primary outcome. In terms of target lesion failure, the simple crossover group has a 7.0% until 5 years, and the side branch open group is 6.7%, statistically no difference. Not only primary outcome, but also secondary outcome, death of any cause, no difference. Myocardial infarction, also no difference between two groups. And then any revascularization, target lesion, target vessel, there is no difference between side branch opening group or just simple crossover stenting group. Because of a different baseline characteristics, we have to do IPTW adjust analysis, and then that adjust analysis result also, there is no difference between two groups. This is Kaplan-Meier curve. As you can see, the target lesion failure instance between simple crossover red line and blue side branch opening group is no difference. Cardiac death and target vessel MI and target lesion revascularization is also no difference between two groups. You may think about the, this is a real world registry data, and then also the large number is non-left main bifurcation. And then if we select left main bifurcation, or how about if we just select the true bifurcation reason, here is the result. If we compare the left main or non-left main bifurcation, there is no difference. In non-left main bifurcation reason, simple crossover, side branch opening, no difference. Even in left main bifurcation, statistically no difference, but the side branch opening group has a little bit higher, numerically higher event rate in left main bifurcation. How about the true bifurcation reason? Also similar result. Non-true bifurcation reason, no difference. And true bifurcation reason also statistically no difference, but the numerically side branch opening group has a little bit higher event rate. Not only left main and true bifurcation reason, but also we are very interested in the usage of IVUS can affect clinical outcome. But as you can see, there is no difference. If we just do the simple crossover stenting with one stent technology technique, you don't need to worry about whether you use IVUS or not. And also do POT or not, no difference. And also, when we do this, just a simple crossover technique, there are many argue about the risk of a side branch restenosis rate. So here is the instance of target lesion revascularization. Simple crossover and side branch opening group has no difference until 5 years. And if we just select a side branch osteum, side branch related TRR instance also, no difference. Portion of a side branch related TR rate was no difference between two groups. So just to say, I may say that in this COVID-3 real-world large registry data bifurcation PCI, when we just do the simple crossover stenting, side branch opening do not affect the clinical outcome. So you may have a question. So why there is no difference? How can explain that kind of mechanism? This study also performed by Dr. Gu is a CFD using CFD study, just a simple crossover stenting and measure the wall shear stress. The blue line is low wall shear stress, which can induce the augment neo-intima hyperplasia. And even though it looks like a pinched side branch osteal, but the red color means a high wall shear stress, and then it's a very low chance of starting of neo-intima hyperplasia. And also, if we do the side branch opening, just the seeing of ostium looks like enlarged by side branch opening, but what important thing is blue color of main vessel area was increased. That is a very serious problem because the increased number of wall shear stress area in main vessel will make a poor outcome, really clinical poor outcome to the patient. And also, when you do the serial OCT analysis, after just a simple crossover stenting, ostium of a side branch a little bit decreased. But when you follow 1 or 2 years later, the area of side branch ostium was not changed. That's why we can say that it is very safe without any additional procedure. And also, we are concerning about whether that kind of stent strut of side branch opening site, is it okay? So we do the serial follow-up OCT analysis, and then we find out that most of the stent strut was covered after 1 year later. Another issue is whether we can say that by OCT, stent strut of side branch opening side was covered, but whether that is a healthy neo-intima or very serious neo-intima. This case was presented during the 2018 CCT and from Japan doctor, and they showed the angioscope of that side branch strut. Not just covered, but it looks very white, looks very healthy. Neo-intima was covered in the side branch ostium strut. That's why the clinical outcome was not different between two groups. So this is, as I mentioned, that non-randomized retrospective observational study, but it's included patient is more than 2,000 of patients. Is really big registry data, and we followed until 5 years. It's quite long follow-up duration. So there are so many limitations in this study, but I may say the long-term clinical outcome of a simple crossover one stent strategy without additional side branch opening procedure in patient with coronary bifurcation lesion was acceptable, even for the left main or true bifurcation lesion, but it's very simple true bifurcation lesion. And therefore, additional complex procedure like lipa, kissing, after with side branch opening may not mandatory for simple crossover stenting bifurcation lesion. Thank you very much for your kind attention.
Hi, thank you, Dr. Nam, for your wonderful introduction to the manuscript published in the first issue of JACC Asia. Any more questions and comments? So from our panelists.
Dr. Nam, congratulations for your excellent studies from the COVID-3 registration. According to studies, actually the beautiful studies show actually there is no need to routine do the side branch opening with kissing blue inflation or port compared with only simple one stent crossover. You also have robust data with a longer term follow-up.
at either left main or non-left main bifurcation lesions. Actually, this I think real-world studies has duplicated and reconfirmed the Nordic 3 studies for simple simple bifurcation lesions actually routine do the kissing balloon inflation were not other additional benefit for patients' long-term follow-up. So actually, I would like to know what's your further option or further maybe studies that you will do according to your COBIO-3 studies. In my opinion, so far we still don't have a strong data, especially for left main bifurcation lesions, for simple left main bifurcation lesions. If we treat it with a provisional stenting, do we still do the kissing balloon inflation to open the stent seal? Because in terms of left main bifurcation, the side branch is circumflex, is a major epicardial vessel. So if we don't do the kissing balloon inflation, we still concern the long-term the stent structure just over the osteoma of a circumflex, and with developed, I think we still worry about the endothelialization where pinched the osteoma of the circumflex. So I would like to have your options. Thank you very much.
Yeah, thank you, Dr. Zhang. Yeah, it's very important question. So in non-left main bifurcation, we don't worry about that kind of concept because already confirmed. Even though FFR is low, it means really functionally jailed the side branch, but clinically no difference, whether open or not, because its myocardial territory is too small to make a different clinical outcome. But as you mentioned, the circumflex is totally different. It's big myocardial territory. So we are concerning about that kind of area. So first, according to our study result, so if the left main bifurcation is a simple bifurcation, it means the osteum of the circumflex is not much disease. In that that situation, just a simple crossover will be enough. Even though we additional complex procedure to open the strut of side branch circumflex osteum, but there is no clear way to remove the strut of circumflex osteum. Sometimes if you follow the OCT guidance, right wiring selection, location of osteum, and also the various complex procedure, but we cannot remove the strut. That's why still no difference in clinical outcome. Especially, I also already showed the OCT follow-up study, serial OCT study showed the covered neointima as looks very healthy. That's why I think it's just a medical therapy user case, medical therapy will be enough. But I may say it will be better to use a thinner strut. And also recently we use a second generation with the biodegradable. That will be maybe theoretically beneficial to cover with a healthy neointima earlier than the thicker stent. That's another concept. But one issue is that our registry include very simple left main bifurcation. So lesion length is very short, and then percent diameter stenosis of a side branch circumflex is also very low, lesser than 50. So we don't include it in our study very little bit large plaque burden in circumflex osteum. That case we need more data, because we don't have enough clinical data and randomized study about whether additional complex procedure will be beneficial or not. So we have to wait the clinical trial result from the EBC. But unfortunately, EBC, they do hold the patient was perform the kissing balloon. So we need more data in the future.
Thank you.
I have one small question. I think this study is interesting and answer the important question in the case level. Maybe when we open the side branch, actually the I mean sometimes the wire in the distal of the atrium, that means near the carina. Sometimes the wire is near, at the proximal of the atrium, that distal to the carina. So I think the prognosis of the procedure when we open the side branch is different. And maybe the prognosis of these two procedure also different. So I agree that maybe crossover without open the atrium of structure of LCX is not only simple but also safe. But I think the prognosis of different way to open the structure at the atrium of LCX is different.
Yeah, Dr. Pu. Yeah, it's a great point because many Japanese doctors do such kind of way because previous EBC consensus say that when we do after simple cross-up stenting, when we open the side branch, they recommend the distal rewiring, right? So, but according to Japanese OCT study, they show that just the angiographic distal rewiring is not enough because even though we do the distal rewiring, sometimes that is wrong way. They cannot remove the whole strut from the ostium. So they said the OCT guidance rewiring can only select the right way. So it is a very limited situation because the OCT guidance bifurcation PCI can be performed very limited number outside of Japan. Still in Asia, we use very frequently use the OCT, but still the number is lesser than 30%. Outside of Asia, Korea, China, and Japan is a relatively high instance, but outside of Asia, lesser than 10%, sometimes lesser than 5% OCT guidance, especially it's only can be performed by OCT guidance. So if we can do OCT guided rewiring and then do the careful kissing and lip-out technique, I may say the clinical outcome will be good. But if we cannot do that kind of way, just the routine, the angiography, the side branch opening cannot make a better outcome because it's a little bit complex procedure and the high instance of complication.
Thank you.
Hi, Dr. Lang. Congratulations.
Thank you.
So, if side branch FFR is less than 0.8 after the crossover stent, so is there still no difference between the with and without side branch opening?
Actually, we don't have that kind of a clinical follow-up study. So just doing the FFR measure and then see the clinical outcome. Even though this number is not much, but it's quite big difference clinical outcome. So if FFR, the circumflex FFR is low, if we follow just medical therapy, the event rate is very high, looks high. If FFR is high, it's quite acceptable. So if FFR is low, then what can we do? That is a very important thing. So still, we don't have enough clinical data about that, but we have to open that side branch with just a balloon, or sometimes we need a provisional second stent strategy, implantation strategy. We have to do sometimes. Yeah.
Okay, thank you.
Thank you, Chairman and panels. My topic is the coronary physiology assessment in acute MI. No disclosure. Let's see this acute MI case. This is a 76-year-old male. He had chest pain and diagnosis as acute anterior STEMI. Angiographic, there is a significant stenosis located in the left main bifurcation and with multi-vessel disease at LAD, LCX, and RCA. Others confirm the significant stenosis. So for this patient, my PCI strategy is primary PCI to left main bifurcation, the crossover with gel balloon, and stage PCI for LAD and LCX. After primary PCI, the final TMI flow is TMI 3. After 1 month, the patient came back for static PCR for LAD and LCX. However, after 1 month, angiography showed the vessel looks better. In ours imaging, the MLA became larger. We performed the FFR for LAD and LCX. FFR is 0.8 and for LAD and 0.9 for LCX, so we do not need to protein stain for this patient anymore. We know acute MI is a complex pathology, and microvascular obstruction, tissue inflammation, and spasm could lead to false appearance in STEMI, especially in acute phase. Question 1. Physiology assessment of impact-related artery in acute MI. We know ischemia impacts distal RA vessel motion by decreasing the vasodilation ability. During acute STEMI, the degree of damage to the infection-related myocardial bag makes FFR in RA may be inaccuracy. Because of maximal hyperemia might be blunted, which could induce the overestimation of FFR. You can see flow may be recovering in a days following the infection, and hence the previous negative FFR in the acute phase of STEMI may become positive in a late phase of STEMI. How about the post-PCI FFR in acute MI? Previous studies show that in stable CAD patients, lower post-PCI FFR was associated with higher vessel-related cardiac events. How about post-PCI FFR in STEMI patients? Recent studies, STEMI patients undergoing primary PCI of infarct-related artery and underwent post-PCI QFR at state PCI. This study showed low post-PCI QFR was an independent predictor of 2-year vessel-related mass. Question 2, physiology assessment of non-infarct-related artery in acute MR. STEMI with MVD is common, occurs about 50% of STEMI patients undergoing primary PCI. 10 years ago, the guidelines discouraged the non-infarct-related artery PCI at the time of primary or rescue PCI in stable STEMI patients. However, with the development of intervention cardiology, several studies showed complete revascularization was associated with better prognosis. In STEMI, stage MVD PCI was associated with low mortality compared with the infarct-related artery-only PCI or single-stage MVD PCI. We can see the physiology assessment of non-infarct-related artery in acute phase of STEMI is feasible. In STEMI patients, FFR-guided complete revascularization of non-infarct-related artery in the acute and stage setting, resulting in a low risk of cardiovascular mass. So current STEMI guidelines recommend routine revascularization of non-infected related artery before hospital discharge, especially under the guidance of FLAVOUR. Question 3, physiology assessment of microvascular dysfunctions. We know epicardial flow does not equal to myocardial reperfusion. Microvascular dysfunction is an important pathological change after reperfusion therapy in STEMI patients. About 2/3 of patients may have microvascular dysfunction. However, there is no accuracy and simplified assessment of MVD, especially in the acute phase of STEMI. Let's see 2 cases. The first patient is a male patient with capillary lesions at proximal LAD. After primary PCR, the epicardial corner flow was TIMI flow 3. The second patient was also a male STEMI patient with capillary lesion at proximal LAD. After primary PCR, the epicardial corner flow was also TIMI 3. So from the clinical and angiographic feature, we cannot see any difference. However, when we follow up these 2 patients at 1 month, case 1 7 days, but case 2 not any events. So why? Similar clinical features of these 2 patients, but different prognosis. We can find the answer from in-hospital CMI. The first patient from the CMI, we can see a significant perfusion defect and microvascular obstruction. Case 2 only the edema on the CMI imaging. We know CMI is a golden standard for MVO. However, CMI cannot be performed at the same time of primary PCR. Now, FFR and IFR are common performed as guideline recommended tests for evaluating epicardial coronary artery disease. For assessment of microvascular dysfunction, 2 methods have been developed, especially IMR. However, both operations are relatively complex. We recently published a study to use QFR for predicting microvascular dysfunction in STEMI. We know QFR can be obtained to use 2 different flow models. One is fixed flow model, calculated by pullback with a fixed FFV that was from previous FFR studies, 0.35. The other is contrast flow QFR, CFR, which uses HFV from coronary angiographic. We hypothesized that QFR computation could be used to predict MVO after STEMI. Why? We know when MVO is present, microvascular resistance cannot be ignored. Result, FFR is overestimated. So FFR and FQFR is identified as QFR in the absence of MVO, and CQFR is identified as QFR in the presence of MVO. So the difference between FQFR and CQFR maybe indicates MVO. In our study, we can see the difference of CQFR and FQFR is an independent risk factor for MVD in STEMI patients, and the count point was 0.07. I see the 2 patients. The first patient was 62-year-old male with acute anterior myocardial infarction. The team flow was 3, the CTFC was 32, and we calculate the CQFR and FQFR. And we can see FQFR was 0.038, CQFR was 0.4. The difference of CQFR and FQFR was 0.02, less than 0.07. QFR system predicted MVO was not happening. So when we perform CMI for this patient, we cannot find MVO. The second patient was a 66 male patient with acute anterior MI. We can see the TFG, the team flow was 3, the CTFC was 52, and we calculated the QFR. FQFR was 0.58, CQFR was 0.71. The difference was 0.13, larger than 0.07. A QFR system predicting the presence of FAD. When we perform the CMI, we can see significant MVO was detected by the CMI. The conclusion. FFR is not recommended for detecting infarction-related artery in acute phase of STEMI. However, post-PCI assessment was feasible for infarction-related artery at stage PCR for prognosis. For non-infarction-related artery, physiology assessment of non-RIA in acute MI is relatively accurate. FFR-guided complete revascularization of non-infarctor in STEMI is recommended. For microvascular dysfunction, we can see physiology assessment can predict MVO after STEMI intervention. Thank you for attention.
Okay, thank you very much, Dr. Pu. Very interesting study. So any question to Dr. Pu Jun? So Pu Jun, congratulations for your very interesting study. My question is, you mentioned if the data CQFR to FQFR is less than 0.07, it suggests there's no microvascular disease, right?
Yeah.
So what's the evidence for the cutoff to 0.07? So why you choose the cutoff for 0.07?
Yes.
For the data CQFR to FQFR.
Yes. We performed this study to investigate whether QFR, especially the difference of FQFR and CQFR, can predict the presence of MVO in the study. We use, as we know, the FQFR is identified as a QFR in the absence of MVO. CQFR is identified as QFR in the presence of MVO. That's why we do not measure the FFR in acute phase of STEMI. But according to this principle, we can use this difference to predict the MVO. The cut point of 0.07 is come from it comes from the regulator analysis. We use different parameters and found the AUC at the cut point of 0.07 is largest. So we use the cut point of 0.07 for the difference of CQFR and FQFR.
Okay, thank you.
So I have one question. So that thanks for sharing the wonderful and excellent idea and the beautiful demonstration of the MBO. The question is, either use CQFR or the VQFR, you're using the resting anatomy and resting flow. So the question is that for you to delineate the hyperemic resistance, you have to put some assumption for CFR and the hyperemic flow versus resting flow. So the practical question is that unless you have a hyperemic flow velocity, so there's some limitation in applying only the resting flow velocity to estimate the hyperemic flow velocity. So that do you have any validation for resting resistance versus hyperemic resistance and applying the resting flow velocity and hyperemic flow velocity?
Yes, I agree with you. Because maximal hyperemia might be blunted, which could induce overestimation of FFR. But for QFR, because QFR is termed computational FFR, the QFR can be obtained with two different flow models. FQFR it comes from previous FFR study. It's fixed, and the contrast flow QFR is is use actual HFV from coronary injury. So in our study, we used QFR without the hyperemia. I think because as you said, QFR is computational FFR, and it has its limitation. But for our study, we only calculated the difference of FQFR and CQFR to find the difference of the real flow speed and the fixed flow speed. So the difference can reflect the presence of microvascular dysfunction or not.
So I'm very impressed in your very genius idea. So I have one question that the FFR, CFR, the difference would be better than the Timmy frame count or Timmy flow?
Yes.
To predict the MBO?
Yeah. Yeah. In the FQFR, the calculation of FQFR is not dependent on the CTFC. But the CQFR, when we calculate CQFR, we use CTFC. That means the frame of the angiographic frame. As I showed in these two examples, the first patient, we used when we calculate the CQFR, we use the CTFC of this patient. This patient is the frame is 32, but the second patient is 52. But for this patient, the FQFR, the fixed speed is the same. So we can see the difference of CQFR and FQFR could reflect the presence of MVO or not.
Thank you.
Thank you.
if I may have just one last comment, I think it was marvelous. The culprit vessel is indeed difficult to assess, but my question as always is, this QFR method looks novel, maybe IMR, but I think we need to move one step to say that once you get these indicators, what is the therapy that you think will change outcome to reduce events from any form of MVO? I think currently we still don't have very good assessment of where is the target to hit in a STEMI intervention in terms of what to do after the epicardial artery is open. I think we do need more studies to see where it can change the trajectory and outcome for this group of patients. Thanks a lot for the work.
Thank you.
Hi. Because of time limitation, so now I'm going to close the wonderful webinar. I would like to use Chinese old saying. So all good things must come to an end. 没有不散的宴席. So dear all of our attendees, moderates, panelists, speakers, and audience, highly appreciate your great contribution to JACC Asia webinar series on coronary physiology update. It's wonderful and thoughtful presentations with plentiful discussion covers almost all important topics in the field, which will be, I think, very meaningful to our to both of our daily practice and thinking of future clinical studies. So thank you again. Looking forward to meeting you in near future. Thank you. Thank you all.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.
Bye.